Calcification is one of the main reasons endovascular treatment for PAD fails. Up to 80% of patients have significant calcium, and this increases the risks of dissection, recoil, embolization, and early reocclusion. IVL has rapidly been adopted in UK practice, but we still have no randomised evidence showing that it improves outcomes compared with standard angioplasty. RAVE directly addresses this evidence gap. It is the first pragmatic RCT powered to detect differences in major adverse limb events, including death, major amputation, and clinically driven reintervention. IVL allows controlled, circumferential modification of deep and superficial calcium using low-pressure balloon inflation. The technology can reduce the need for high-pressure inflations, reduce dissections, and potentially reduce stent implantation. However, none of these perceived benefits have been proven in a randomized environment. RAVE provides the robust comparative data needed for guideline committees, NICE, and commissioners. RAVE is deliberately pragmatic. Randomization is performed before the procedure takes place. The patient is allocated to one of two arms, IVL treatment or no IVL treatment. Once the lesion is crossed, the allocation is revealed to the operator performing the procedure. The primary endpoint is a composite of death, major amputation, or clinically driven reintervention at 12 to 24 months. Secondary outcomes include quality of life, EQ-5D, procedural complications, health service utilization and cost-effectiveness, and core lab analysis of lesion morphology pre- and post-procedure. The sample size, 306 participants across 24 sites, provides adequate power to detect clinically meaningful differences. RAVE answers the question every UK centre is already facing. Should IVL be used routinely for calcified peripheral arterial disease? Any lesion with calcium can be randomised, as long as the local team feels that lithotripsy can be used to treat that PAD lesion. Without RCT evidence, adoption decisions rely on observational data, industry reporting, and operator preference. By recruiting, you help generate definitive evidence that will inform international guidelines, NHS commissioning, and improve outcomes for patients with heavily calcified PAD. The protocol is simple, workflow disruption is minimal, and recruitment supports national PAD research priorities identified by both clinicians and patients.